Good morning. It is a pleasure and honor to speak to you regarding medication errors in the operating room. My name is Elizabeth Rebello, and I am a professor of anesthesiology at the University of Texas, MD Anderson Cancer Center in Houston, Texas, in the U.S. I also serve as an APSF board member. I have no financial disclosures. I do serve on the USP Compounding Expert Committee and also on the FDA Pharmacy Compounding Advisory Committee, but these are both voluntary roles. My objectives for this talk are to talk about the differences between both feedback mechanisms and constraints in the medication administration process, to look at the multifactorial issues regarding labeling of syringes and some of the intricacies associated with that. We'll look at some of the look-alike vials in the medication safety environment and also talk about smart pumps and standardizing some concentrations. When I think about one of the first medication errors that I encountered, I was a resident and the attending was taking care of another patient and it inadvertently gave the patient rocuronium in place of midazolam in the holding area. The vials looked extraordinarily similar. And he recognized this error quickly, and as a result, he was able to intubate the patient, take the patient to the operating room, and the patient suffered no untoward effect. However, frequently that's not the case. In fact, medication errors are the most common type of medical error in the U.S. And every year, it's thought to between 7,000 to 9,000 patients die in America as a result of a medication error. In terms of injuries, over 1 million people are injured because of a medication error in the U.S. yearly. And in terms of cost, more than $40 billion are spent caring for patients as a result of a medication error. The World Health Organization has recognized that the global cost of medication errors is almost 1% of the total global healthcare expenditure. In fact, because of this issue, the WHO dedicated 2022 World Patient Day to increase awareness around medication safety. There was a case here that received a lot of publicity involving a medication error last year. And the events actually preceded that for a few years before. I'm just going to describe it to you in some detail because this issue involved the criminalization of medical error. And so this case was actually something that occurred in December of 2017, where a nurse working in the non-OR space, it was actually a radiology suite, and this was normally not her work area. She was pulled in as a resource nurse. There was a trainee shadowing her, and she inadvertently gave a patient vecuronium in place of midazolam in this radiology suite. The patient was not monitored, and the patient died. In March of 2022, this nurse was convicted of both negligent homicide and gross neglect of an impaired adult. Now, there's several issues that come to play. One, this nurse had never given vecuronium or midazolam before. She did not know that vecuronium needed to be reconstituted and midazolam did not. She withdrew the medication from an automatic dispensing cabinet, which is a frequent source of medication storage here in the U.S. But unfortunately, she typed in VE, only 2 letters were required, and she used the brand name. And what pulled up was vecuronium. And since then, there have been some changes in terms of software within the U.S. because of this error. The nurse was sentenced to 3 years probation, and this really caused a stir because think about it, the nurse had pure intentions, and unfortunately, we call it here the Swiss cheese model, and a very, very unfortunate event occurred. The APSF then formed a task force in May of 2022 and created a statement regarding the criminalization of medical error. and really determined that prosecuting healthcare professionals when an error occurs actually does the opposite of what we're intending. It decreases reporting, it creates an environment of fear, and overall affects patient care in a negative manner. In terms of medication errors are thought to occur in 1 out of 20 administrations, and the most common types of errors are incorrect dosing and substitution errors. Incorrect dosing can be addressed with standardized concentrations, and I'll discuss that a little later. And substitution mitigation effects include using pre-filled syringes. The Spanish anesthesia reporting system looked over 10 years of errors, and medication errors occurred in 28% of the 4 phases of medications, the medication process. That is prescription, preparation, dispensation, and administration. Administration was the most frequent and also had the highest harms. When you look at the anesthesia care as a whole, there's the machine side and there's the medication side. And when you think about all of the different technologies that exist to help us on the machine side to prevent an error from occurring, we have color-coded gas lines, we have pressure and flow sensors and alarms, colored vaporizers, flow meters, and there's a machine check. But when you look on the medication side, there's no alarm that goes off when an error occurs. There's really no way to detect an error. And there's no real way to check a dose prior to administering a medication. There are some things that do help us. There are feedback mechanisms and constraints. Feedback mechanisms involve some compliance to the feedback, and these include color-coded syringes. You have to actually look at the color, know what the color means, and that can serve as a way to prevent a medication error. We have barcode scanners, but there's always issues around barcode scanners where there are workarounds that exist. There are labels, 2 provider checks, and alarms. Constraints are different. It's actually a system created to help prevent the human error from occurring. And some of these examples include pre-filled syringes, which eliminate a whole host of steps in the medication administration process. Having pharmacy medication concentration standardized to 2 or 3 rather than having many concentrations, which can lead to a medication error. And then if you're using an infusion pump, having what we call guardrails built in the software that prevent a significant overdose or underdose from occurring. So what do some of these constraints look like? These involve standardization of medication concentration and also allowing some automated processes without really impacting workflow. So here's one example. This study looked at pre-filled syringes, and in blue are the steps and then these steps have been broken down to sub-steps. In this study, actually divided into 5 different big steps. And by having pre-filled syringes, 6 of the sub-steps were eliminated. As you can see, 19 of the failure modes. That whole section of preparation was eliminated. And some may also argue, from an infection control standpoint, it is more beneficial to have a pre-filled syringe. Excuse me. Next, I'd like to talk about variants. There's variants that having different concentrations can lead to increased harm associated with administering medication. And this study here looked at the surveyed pharmacy directors and quantified the different number of different concentrations of medications. And as you can see, with some of the medications in anesthesia, there are many. For phenylephrine, there were over 45 different concentrations. And for medications such as epinephrine, 37. So the idea is to create fewer concentrations locally and perhaps nationally to help mitigate this effect. The American Society of Anesthesiologists actually looked at closed claim studies and involved several different committees and actually came up with 10 medications that should be considered to standardize. And it's not that they should only be one concentration, but maybe 2 or 3 at your institution rather than having 6 and different ones in different locations. Many of you may not recognize this face, but in the U.S., this gentleman has a very famous face. He's a famous actor named Dennis Quaid. And about a little over 10 years ago, Dennis Quaid had newborn twins, and his newborn twins received over 1,000 times the dose of heparin. Each twin received that dose twice. And this luckily did not cause any untoward effects for his children. However, it really stirred up some angst regarding why this is occurring. And Dennis Quaid actually spoke to Congress about these errors that are occurring due to concentrations. Now let's switch gear and talk about labeling. The American Society of Anesthesiologists has a statement looking at labeling with recommendations based on some of the standards. And as you can see in the picture here, for a prefilled syringe, the labeling actually varies. The APSF had done a survey a few years ago, and for anesthesiologists in the U.S., and providers over as a whole, anesthesiologists and nurse anesthetists and anesthesia assistants, the preference was to have the concentration per cc versus the total concentration. The reason is there's a mathematical process that's eliminated by having it per cc. But if you look here, the prefilled syringes look different. And that's because it depends on where the syringe is sourced. If it's sourced at a 503B compounding facility, their regulations are different than if it is sourced from a manufacturer. And that's why these look different. The USP recognizes that in certain situations, it's important to have the medication per cc rather than having the total amount over the total volume. And one example of this is insulin. It's recognized that having the total concentration of insulin over the total volume would not make sense in this instance. In addition, for local anesthetics, there's also been some changes made. So as you can see here, when you look, the first diagram looks at how difficult and how similar these vials look. And there's a mathematical, whether you're giving either of these medications, there's a mathematical process that needs to occur. We have to divide out to see how much medication are you giving in 1 cc, and then consider the dose accordingly. And yet, when you look at the insulin vial, it actually tells you it's 100 units per cc. So it's a little bit easier to give this medication because you know how many units are in 1 cc. You're not having to make that mathematical calculation. And with local anesthetics, there's actually an option of doing one or the other. I'd like to now focus on infusion pumps. Over a 7-year period, there were over 50,000 adverse events associated with smart infusion pumps. And because of this, the Indiana Coalition for Patient Safety partnered with Purdue University and created this project called Remedy, looking at all the different concentrations and data from all the different pumps of members that participated in this project. The database was extensive. It was actually over the majority of our states and had some international presence with with almost 200 million records. This group published some papers on medication safety with regard to infusion pumps. However, with the pandemic, due to funding, this whole effort was sunsetted. So now it's really a team and a local effort at your institution to look at the different concentrations and try to standardize those concentrations, and also look at your pump information and make sure it's accurate. You want to balance the risk of patient harm with what's achievable at your institution. Another item that's really been an issue are these look-alike vials and ampules. And this has also been heightened as drug shortages exist. In the diagram with the tray, you can see that there are several different versions of ondansetron from different manufacturers. And having that present can lead to a medication error. And one of the recommendations is, even if it means having fewer, have the same type to help prevent a medication error from occurring. Two other examples I'd like to present with are the examples of drug errors in the literature. And this is an error that continues to recur. This is where tranexamic acid has inadvertently been given in place of bupivacaine. This study looks at 20 cases in which 10 patients died. The study's from a few years ago, but the error continues to recur. In fact, this error occurred twice last year, once in the US and once in Canada. So we need to talk about involving manufacturers as well in this conversation to make medication safety a priority and include them. The APSF has created a bank on their website to where anyone can log onto their website, take a picture when they see a medication vial similarity, and enter that into the system. And the idea is that having this robust form of information can hopefully help with advocacy efforts in the future and also create awareness among trainees and providers. So the second medication I would like to bring up is phenylephrine. And often we see phenylephrine in this formulation, 10 milligrams per cc. But if you think about it, it actually has to be diluted twice to be administered. And this issue actually is that there's 100 times the standard dose in this vial. And when one looked at errors in the preoperative setting, 10% of errors were from this. At my institution, phenylephrine is in a prefilled syringe, and it prevents this type of error from occurring. The APSF in 2022 convened the patient safety, medication safety priority group. And as you can see here, there are representation from physicians, nurse anesthetists, pharmacists, nurses, attorneys, industry, and such. And these were the 5 recommendations that were made. They are that prefilled syringes should use when possible to help decrease medication errors. When possible, electronic medication scanning, both to take it out of the medication dispensing cabinet and also upon administration, would make medication administration safer. This is an example of a feedback mechanism. The APSF should work with regulatory bodies, both nationally and internationally, and also manufacturers to help standardize medication vials. It's interesting, similar to the color coding labels we have for syringes, the ophthalmologists have actually color coded the tops of their vials, and this may be a consideration in the future. APSF also recommends the standardization of concentrations of medications across the different patient areas. And this highlights the example I brought up with Dennis Quaid and how some of the effects can be prevented with standardization of concentration. And then lastly, when we think of all the different countries and all the different resources, they are very different. So having a toolkit as a resource for anesthesiologists in different countries would be something of benefit as well. So in conclusion, there are some takeaways I'd like to send you home with, and that is, when possible, use prefilled syringes. Talk to your hospital systems about the benefits of prefilled syringes. We in the U.S. have found that although there may be an increase in cost, when you think of the potential of a medication error and the cost of a medication error, the benefit for a prefilled syringe far outweighs the cost. In addition, consider standardized concentrations. This is something that we can do to help medication administration safer. And lastly, the utilization of smart pumps when available. It's important to think about the look-alike ampules and vials and some of the risks involved in that, and educate trainees and providers regarding this. And then lastly, maintain vigilance with medication safety. It's been a pleasure to speak with you, and I look forward to taking your questions.